Our next panel, M&A Considerations in Behavioral Health, will begin right now, featuring Andrew Sfreddo, Jacob Lynch, Tim Doran, Tani Weiner, and Todd Rudsenske.
All right, can everybody hear me? All right, very good. Well, welcome. Thanks so much, everyone, for coming. We have an hour here to talk about M&A in the behavioral healthcare space. We have an esteemed panel here and excited to kind of have some good discussion. We're going to run through some questions, some topics within the industry, and then want to leave some time towards the end for some healthy Q&A for our panelists here. So without further ado, I'm just going to do some quick introductions, and then we'll go ahead and get started. So my name is Andrew Sfreddo. I'm the head of behavioral healthcare at Blueprint Healthcare Advisors. We're a middle market, lower middle market advisor, broker in the space. We traditionally focus on higher acuity with an inpatient kind of real estate component. And I'll let Tani to my immediate right here introduce himself, and we can just kind of go on down the line, and then we'll go from there.
Thanks, Andrew. Great to be here with everybody. Thanks, BHASe, and everybody for making this a great conference so far. My name is Tani Weiner. I'm a partner at the Polsinelli law firm and co-chair of our behavioral health law group. Polsinelli is national full service, focusing on healthcare, mergers and acquisitions, real estate as our core practice areas. We have 25 offices around the country, and I lead our group, of which I've got a number of team members here, in doing M&A and behavioral. I've been in the behavioral space doing these deals for about 20 years, and delighted to be on the panel.
Likewise, I'm Jacob Lynch. Worked with all these guys before, admire them, trust them, definitely seek out their advice, but delighted to be here. Thanks for having me. I'm a partner at BHX, Behavioral Health Exchange. We're the host for the conference, and it's a somewhat new firm, although we've all been around many, many years in this space, doing M&A deals and consulting. We're trying to set a new standard here, so glad you're here. Excited to meet all of you.
You have set a new standard. Nice event. And Todd Rudsenske, I'm a partner at Webster Equity Partners. We're a private equity firm that invests exclusively in healthcare. I've been in the healthcare sector for 25 years, 15 of which I've spent almost all my time in behavioral. At Webster, we have 6 portfolio companies. We'll have the opportunity to share a little more about them through the discussion, but we have the largest MAT provider in the country with Baymark, Discovery, where we've acquired a business from Tim, where Tani's also serves as legal counsel to the company. We have a autism therapy business. We have a psychiatric hospital business, Oceans Healthcare. Daryl Doyes is here, our Chief Development Officer. Do a lot of partnerships and geropsych in that business. We've recently invested in a Medicaid mental health business in the community serving Baltimore. So a lot of different areas in which we've invested, and hope to share more of that with you today.
Thanks. Good morning. Thanks for having me. Appreciate being here. Tim Doran, Praesum Healthcare. We're a behavioral health, mental health, and substance abuse MSO, headquartered in Lake Worth, Florida, Palm Beach County. Been in business since 2002, over 30 locations, primarily on the eastern seaboard from Boston all the way to South Florida, both from IP psych to partial hospitalization, outpatient, inpatient. Look forward to speaking with everyone today.
Perfect. Thanks, guys. All right, we're gonna kick things off with a little bit of history, evolution of the space. So I'd like to revisit the growth and the evolution of behavioral healthcare here for a few minutes and discuss where the higher acuity behavioral healthcare industry was 10 to 15 years ago, and what are the main aspects that are really different today. So Tim is a established operator with over 15 years of experience in the space. Can you help us understand what are some main key aspects of the space that have changed over the past 15 years?
Sure. I would say the biggest change is the relationship between the provider and the payer. If that is not growing and maturing and being taken care of, literally 24/7, 365, whether it's on a consulting basis or internally, managing those relationships. 15, 20 years ago, insurance companies, the standard line was the network's closed. And everyone was in an out of network position. To stay in this business, you have to continue to offer more levels of care, take care of the patient from the beginning of the cycle all the way to the outpatient, and maintain that relationship, because the payers have really reduced reimbursement. Labor is a big problem, nursing, staffing, clinical. Most of our facilities were constantly in a turnover, fighting wage increase, managing the expectation of the patient and the payer. We do feel that the biggest change is about to happen, which is currently in other areas of healthcare when there's been consolidation. It's been driven by changes inside of CMS. In this particular space, 49% of the revenue that's generated inside psychiatric, if we call that the highest level, is through Medicaid. And historically, Medicaid and Medicare have not really tied together with behavioral health. That's why it's been primarily a commercial product. We believe that's the biggest change that hasn't occurred yet. It's in the process of occurring. Regulations occurring to open up the doors. And that's where we see an MSO will be able to be a consolidator of consolidators.
Very good. Has anything else to add to that? What Tim had to say at all?
Yeah, I guess two quick observations. Some of the biggest changes I've seen over the past 15 years, really starting about 2006, 2007, is destigmatization. And wow, where we are today, the number of people that speak openly about challenges with mental health, depression, family members that have, had tragedies from suicide to deaths from overdose. These are things that people used to try not to talk about, and now there's just a lot more conversation about that. So, I think that's going to continue to drive change, and I think, to your point, Tim, seeing more integrated care. When you go to a primary care doctor and they do a behavioral health assessment, just a lot more opportunities for people to get awareness that you can find these services, and I think an opportunity for us as an investor is to help deploy capital where we can get more access points in the communities that are underserved.
Great. Thanks, guys. Let's so now that we talked a little bit of history, let's talk about where we're going. Where's the future of this space kind of headed? So, Todd, I'll come back to you. As an established investor in behavioral healthcare platforms, do you see certain acuity sectors poised for growth, kind of versus others? And generally speaking, where do you see scale and consolidation in behavioral healthcare coming up here?
Well, as mentioned, we've made an investment in 6 different sectors, so there's a lot of different places where we see opportunities. I think right now, when you look at the landscape and you see some of the companies that have been more in the press for providing access to psychiatrists or psychologists, the Cerebrals of the world, the talk spaces, the life stances, the refreshes, I think that's really, really interesting. It's a little more of a commercial product. To Tim's point, agree so much with his commentary on the opportunity to serve more of a Medicare, Medicaid population. And when I think about that area being underserved, it's really more the seriously mental ill. And so when we think about our investment in Oceans, really a very big geropsych population that they're serving. And instead of being in the largest communities, they're in places like Opelousas, Louisiana, or Lubbock, Texas, or Amarillo. And those are the places, when you look across the landscape in our country, 50% of the areas of our country don't have access to a psychiatrist. So when we think about where the seriously mental ill going to have the biggest challenge with access, it's in communities like that. So we see that as an opportunity amongst others where we've invested.
Anything? Yeah, go ahead,
Sure.
Tim.
When we talked the last time, we teed off with value-based care. It's a topic. There was just another meeting before this. Anyone sitting here wondering about my experience, and it's common throughout anyone I speak with, Value-based care is a very nice buzzword. We have a few contracts that the providers call value-based care, but if you're in the MA space, ACO space, or other areas of healthcare where there really is a value-based contract, it's not even similar. There's not data shared both sides. That hasn't occurred yet. We're literally maybe early baby steps in value-based care. But if you look at the whole person, whether it's 10 cents or 22 cents per dollar is allocated to behavioral health, comorbidities, hypertension, diabetes, all of the musculoskeletal that have all been dealt with. No one's tied the two together and said, why is grandma not taking her diabetes medication and she suffers from depression? How do we manage both of them to get a better outcome? So value-based is coming. That's where this business is going to be. You can't really focus on commercial and think you're going to be able to manage this payer population going forward.
Yeah, no, it makes a lot of sense. We'll come back to that value-based care here in a few minutes, but let's hone in on everybody's favorite topic. Let's talk about pricing and what that looks like today. So, Jacob, I'm gonna, as an advisor in the space, can you help us understand, where you believe pricing is today and where it's headed in the future with the current, debt and equity markets, and then can you help break down for the audience, by pricing by acuity type and size of transaction and how that's affected right now?
Oh, yeah, it's a lot to that. Let me start with actually the future of pricing that you just mentioned. Obviously, increased rates are changing things the last year or so, year and a half have changed numbers quite a bit. Multiples have come down a little since COVID, but I think it's only on as a whole. I think for the quality asset, that demand has actually risen and the prices have gone up. It's available. But the little shameless plug to fix the pricing issue is our firm is trying to build an exchange, much like an MLS listing service, so that we can be a much more transparent, efficient market. If you go buy Apple or Microsoft or something on a stock exchange right now, you're not going to overpay for it. You know what it's worth. We don't have that in behavioral health at all, so you don't know what something's really worth. So we're going to try to compile data to make that pricing structure much more transparent and efficient for everyone, so that it's a much more fair opportunity. And the pricing will therefore be a lot more standard. I kind of gave some explanation there about the current rates, what I see happening next. As far as acuity and size, definitely with size, I don't want to say there's benchmarks, but there's different sizes that are going to command different multiples, much more as they grow in multiple sites. As far as the acuity, most of the pricing is going to be determined by, of course, supply and demand, but also your ability to recreate that income or grow that revenue. So if the reimbursement, if you're getting paid more for high acuity, if there's less supply than there is demand, if there's a shortage of it, then sure, that acuity is going to make that more valuable. But that's not just an every time thing. It's not just if we do more serious care that we're going to be worth more. That's not necessarily the case. There's plenty of people that pay a lot of money and the businesses that are very valuable by doing very simple care because everybody has those issues. There's a huge patient demand for it. So it's much more about the supply and demand and whether or not you're growing market share, providing quality care, than it is necessarily the acuity. The size will definitely matter, right? There's a difference in one location under $1 million on the bottom line and many locations and $10 million on the bottom line. I think Todd would probably speak to that. What he's willing to pay for the two is probably going to vary quite a bit. So obviously size will matter. Acuity not so much unless you're doing something that's going to recreate much more revenue in high acuity.
Todd, anything from the investor side to add to that at all?
I think if we speak about the current market factors that you spoke about, the ones that are different today than maybe they were 3 or 4 years ago, maybe even 2 years ago, EBITDA adjustments. It's a complex world right now when you think about Medicaid redetermination, when you think about labor, what you're paying on staffing. We want to be optimistic that some of that cost will come down if you've been paying bonuses to nurses. But that makes it inherently very difficult to value things after a period of many years of stability where you could see the growth in a business and you didn't have these ups and downs with labor, or is somebody who's on Medicaid today that you're getting paid for, they get to still be on the Medicaid rolls a year from now. That just adds a new complexity in valuing a business. I think you're right. There's certain sectors where multiples have certainly held up, but there's other areas where the credit markets are definitely, with the higher cost of capital, you just see a little less free cash flow there that you can redeploy into the growth of a business. And so it's holding back today some of that inherent growth, which probably makes us a little more conservative. But we also appreciate that there's some nice businesses that are out there, and the really good companies that decide to come out in a market like this are probably really good companies that need more capital to grow. And so if there's competition, to your point, it keeps values at a place where maybe they have been in the past. So.
I found that through COVID, that was definitely the dichotomy we saw begin to happen. Those that thrived through a difficult situation and adapted and figured out what to do were much more valuable. There was all the capital that was willing to go after anything was really going after that. Those that survived and needed the capital, not so much. Their multiples probably went down and people were getting a deal, as we continue to see. And then when you talk about spaces or kinds of businesses, you mentioned the outpatient mental health model, life stands, obviously that's a good exit. Everybody's trying to follow that one, or a lot of people I see, and refreshed it afterward. That's a hot space, as well as, whether it's, however you split the demographics, like I've got people that will say only adolescents, and others that will say, I don't want to touch it if it has adolescents or something. It doesn't really matter as long as you're dominating that space, whatever your niche is, wherever you've got that competitive advantage. I've got a geriatric psych business for sale now, and I've got a emerging psych business that we're about to finish. So space doesn't matter quite as much when you're asking about acuity and which sectors.
Yep. No, it makes a lot of sense. Thanks for everybody's comments. Go ahead. Sorry. Yeah, please.
Yeah, thanks. So from my perspective, it comes down to valuations. I think of it as it's a follow the money play. So it's who is paying for the services, and as Jacob said, what is making some particular business an attractive competitor that a new investor is going to see as having future growth opportunity and be worth something more when it turns around to exit it some 5 or 8 years down the road. If you look back a year ago, everybody was super hot on, as Todd mentioned, Cerebral or all these digital telecompanies, and now they're crashing. Some of them are crashing because of regulatory changes in business model, and you can't do that anymore. And I think if you were to look at this, it would be mostly, or what we see smart investors doing is figuring out what some particular aspect that has sustainable. Right now, legally, we spend a lot of time in due diligence looking around corners to figure out, does this pencil out in parallel with the financial audit to say, like, what are you buying? And smart investors are saying, not only is this a good state where it is now, but what's this going to be like, a year or 2 years down the road? Do we think we can own this lane, or do we think we can do better in this lane? It's more about that as definers of quality and success that we see investors willing to pay for. And I think, to me, on the valuations, I don't know that there's been as much. I think in the last couple of years, there was so much market activity that you could reliably say what would be an 8 or a 7 or a 12 or a 18 or a 23 valuation. I think right now there's a lot of tug of wars going on larger portfolio deals, maybe platforms, and the sellers are thinking that it should be last year. You tell me, Todd, is it like, well, the seller's like, well, I want last year's valuation, and the buyer's like, well, what's this going to be worth a year from now?
A very quick comment. It's been interesting to see there's been a lot of companies that have been willing to come out and test the market, and if they don't get the value they want, it's okay to have a so-called busted process and wait till next year, keep growing your business, and then if you have a specific number in mind, come back then. But if somebody wants to take the opportunity now to buy it, you got to kind of hit that prior valuation. So good term use, tug of war. I think that's what's happening, and it's okay. It's not defeat if you decide not to sell right now.
Yeah.
And I think conversely, the add-on tuck-in deals, there's a lot more activity going on with those because the outlay is not as much, and it goes to what can we be worth next year with a larger footprint.
Yeah, no, I totally agree with that. Let's kind of hone in there for a second, Tani. I think you were kind of alluding to this a little bit, but I want to talk about metrics and diligence for a second here. What are some, you see a lot of transactions with, Polsinelli being in the M&A and regulatory space, serving as counsel. What are some key metrics that you're finding kind of your clients really paying attention to right now? And, also, what are some things that are, making deals go sideways, either terminating deals or causing deals to be repriced right now in this environment?
I'd say billing and coding is a really hot area, and it goes to that same notion of follow the money. If a seller has payer audits or they're on prepayment review or in the chart review process, it's kind of puzzling out that maybe everything isn't quite documented the way it should have been, or maybe the credentialing isn't quite what it is. We've been seeing a lot more attention on that, and it's by necessity. So the great additional opportunity in the space is driven by more funding in the space, both by commercial insurance and, as Tim mentioned, by government pay stepping in. Now, it's all well and good if it's cash pay. You're only accountable to, for the most part, your licensing agency and the patient. If it's out of network, also relatively, if you're licensed, they'll pay you something. But when you get under a commercial insurance contract and you have a big payer with a special investigation unit that's job it is to look for quirks and pull back money and pick fights with providers and get a cut, they do get paid a bounty on what they can recover from providers. It's pretty disgusting, but it's a real life thing. And so a buyer will want to make sure first, that if there is any of this stuff, that there's good answers for it, and also that the way that the practice is going won't be at risk down the road. If you add on top of that government pay, Medicare, Medicaid, I mean, you're in for a world of hurt if the coding and billing isn't right. You can't just sweep that stuff under the rug. Unfortunately, there's affirmative obligations that payers have to make good to the government if there was problems that had come up. And if you don't do that, then you potentially have whistleblower liability, which nobody wants. And you hear whistleblower liability in behavioral. I mean, 5-10 years ago, it would be like, what? Whistle who? Unfortunately, right now, it's more of a factor, which is an insider who found something that wasn't quite right. If they become aggrieved or they want to be opportunistic or something else goes wrong, they can get a cut of a recovery if they rat you out to the government, which is part of what the federal healthcare system is generally in America right now, but behavioral, it has come in much more strongly to behavioral. So there's a lot of areas that you could look around, and we do look around a lot of them, but this is one which really can derail a deal because it gets to where the money is coming from. It gets to the quality of the business, the perceptions of the quality of the business, and ultimately to legal liability, both in terms of clawback risk that you can indemnify against potentially, but even more so, enterprise valuation. If you can't do this practice anymore, all of a sudden your revenues are down, your costs are higher, and your valuation doesn't work. If you hit an issue like that in diligence, you can't just paper around the numbers, unfortunately.
Yeah. Go ahead, Tim.
At Praesum, the first time we ever talked about selling was a PE firm out of Denver in 2011, and they were going to fix our HR and our revenue cycle management. In the early stage, those are the important things. And as you grow and go forward, everything from the exchange that you spoke about, I look in the rearview mirror, other areas of healthcare, ALF beds, SNF beds, ultimately, they kind of come down to a single dollar figure across the continuum of care. To get through that process, the right law firm, we made a decision to bring in a CEO, Drew McCartney, outside of our company, who's been working with private equity for those exact reasons that Tani's speaking about, and everyone on the panel, that you're going to come across issues that you never even realized were a big deal to a private equity buyer who's going to be writing a significant check. And the transaction itself for our company, it's really about a significant piece of it is, if of course you're going to stay in the transaction, is the team you put together, including the law firm and the banker, to make sure that the private equity partner are aligned with you. And if your money's going to be on the table on a go-forward basis, you should plan on a 10-year relationship. And to us, that's where the real value is going to be.
Yeah. I think that segues really well into, go ahead. Did you want to finish that thought?
Very quick comment coming back to the revenue cycle. The one thing that's not changed in 15 years is commercial payers finding a way not to pay you. But I do have some I don't understand AI, but I do have this belief that revenue cycle in the next 5 years could be radically changed by everybody knowing exactly what has to be put into what form to get it exactly right on the first time. And that gives me some optimism for efficiencies, back office. And so I think in this area where we don't see it in most of our other healthcare companies, particularly on the commercial side, where you're sitting there thinking you did everything right and you don't get paid. Behavioral has that complexity to it, and I do think this opportunity with whatever AI means, as they describe it, this is an area that is natural for being able to get it right every time, just like Wendy's is now doing at the drive-thru with artificial intelligence to take your order. So if they can do it there, they must be able to do it with billing and coding and behavioral health.
So I want to take a second. I'm going to come back to you, Todd. I want to take a second to run through a live transaction, right? So, Todd, I'm going to ask you, as an investor in the space, you get a SIM, shows up on your desk. What are some key metrics or table stakes that are important to you and to your firm when evaluating making an investment into a behavioral platform?
Sure. We tend to think of it at a macro level and then at the micro or the company level. A lot of the macro work we do before we get the SIM in. So what's the total addressable market of a particular business? Is this a highly fragmented sector? Is it an area where there's a high growth rate? Or if there's a lower growth rate, that impacts the view on value. So start there, that we don't feel that we really have an opportunity to move forward if we haven't already done that upfront work and say this is a sector that we want to play in. So then that book shows up. You really, one of the first things you look at is the management team and their experience. Certainly when you come to a management meeting, if you get that opportunity, you're really honed in on the team because you already look and say this is a sector we like. Is this the right team and the right business to invest in? You start looking at the individual states that they're in. What is the reimbursement outlook in that state? We spend a lot of time with different advisors that are experts on knowing what the particularly on Medicaid or Medicare, what's the legislative landscape in the state? Are they being supportive of these services? One of the other bigger things that's certainly been true over the past 3 or 4 years comes down to labor. What is their open positions? What are they doing on that front? We could do a whole panel just on that topic. So those are the types of things that we drive into it. It's not often discussed in the book in as much detail for good reason, but once you get that opportunity to spend time with the management team, if they had more capital, where would they want to deploy it? So what are their ideas about how to grow the business? Because there's that opportunity for the initial investment, but then to really have the company grow, you need to be able to make those accretive acquisitions or to put more capital in the business for organic growth, de novos. So those are the things that we use to typically differentiate one company from another, and then drives our investment decision.
Yep, makes a lot of sense. And I want to talk a little bit now about length of stay and just acuity models and how groups are thinking about that. And Tim, I'm going to kind of ask you as Praesum has inpatient, detox, residential treatment, PHP, IOP, counseling services. Tell us how you think about that approach of like a continuum care approach, and why you think it's important for your company to offer these services rather than be really good at detox or resi treatment. Can you talk to us a little bit about how you thought about that?
So years ago, it was advised to be good at one thing within the full continuum of care. That's sort of how the business used to work. We've always felt, when we created the MSO and started to dip our toe into outpatient, IP psych, and other areas of behavioral and mental health, that in order to really service the full patient, everything about them, most patients have a co-occurring disorder. We felt that the payers at that time, which were commercial providers, that they were going to drive the patient down to the lowest level of care. What really happened was telehealth came about, and the payers bought into telehealth as a solution, which it isn't a solution. If you were going to have a heart attack, you certainly wouldn't want to have a telehealth session. The same really is true for the most important part of our body, which is our brain. We feel that you have to take the patient from the beginning to the end and meet them where they are. Otherwise, the patient acquisition cost, the relationship with the payer, and the relationship with the provider-patient is never optimum until you're able to do that, which leads back to brick and mortars, telehealth, and all levels of care in order to effectively do that profitably. It's difficult. There's a lot of pressures. SEO, pay-per-click isn't mentioned, but it's probably the third most expensive cost inside of the commercial SUD and behavioral health space.
And does that, just one follow-on question, does that give you the ability to negotiate with payers, a lot more credibility if you're kind of controlling the continuum rather than an individual, acuity sector?
It's a great question. We decided to put our flag in the Northeast, primarily New Jersey. Even though we were founded in Florida, we chose New Jersey for a myriad of specific KPIs back to population. We felt that in order to impact the payers in that market, you had to have the full continuum of care so that you could treat the patient in their backyard, in their home, where they go to private school, where they go to college. Do I believe that the payers care about it at this point? It's coming. ACOs care about it. Medicare Advantage cares about it. So in order to get there and participate in the growth of this industry, I think that everyone's going to have to look at the full continuum from beginning to end, not just a single level of care.
Yeah. Jacob, I'd like to come back to you for a second on the kind of that continuum of care. Is, in your opinion, are you seeing more attractiveness to investors on the inpatient space, the outpatient space, kind of more this continuum model? What are you seeing out there right now?
I've seen value in both, right? And it's all depending on which buyer is looking for what, but I think it's in line with the whole conversation up here, such as follow the money and what Tim just said. That's a fantastic business, multiple lines, multiple sites, multiple delivery models, et cetera. I mean, anybody's going to want that. It's a great business to invest in. It's attractive, right, to any buyer. If you can't have that, right? I mean, I'm sure he built that over many years, many mistakes, a lot of time and effort and so forth. If you can't have that in starting out, as far as what area is hot, I think you're following the money, right? Like we discussed, where is the most investment going for? There's government money going to places. There is, as the industry kind of integrates with primary care and so forth, there's going to be a lot more money following. As we consolidate it, there's going to be more money. Prices will increase. So I'm looking usually, if I'm thinking about which space is best, wherever the most money is flowing into and becoming the most attractive. I don't think that there's one that's far better than the other or going to be much more valuable. As I said before, it's all however you're performing, right? Is there quality care? Are you growing market share and dominating that niche, whatever it is? And are you really appealing to whoever your target buyer or your end goal is? What's your plan for what you're doing? Serve as many people as possible to exit for the most money, whatever it is. There is a space that probably makes the most sense, the way to pursue that. I mentioned earlier, the outpatient mental health space is obviously hot. There's been a lot in the news lately of eating disorder and ABA therapy, autism stuff. Obviously, those you mentioned earlier from an acuity stance, much more serious conditions. And so if you're getting reimbursed and paid more revenue for that, then yeah, it can be more valuable, it can be a hotter space. That's what's happened in the past. But it all is driven by demand, right? Who's looking for that and for why? As they do their analysis to say, hey, what market is attractive? How can we exponentially increase this based on the teams, and this is the help they need? How can we make a wise investment? That's where I'd be putting my time. That's where I'd be growing. As of something that I would just say, hey, this is the greatest or the best area of behavioral health, I don't have one. This thing's ever changing. It's been SUD, it's been mental health, it's been ABA, it's been eating disorder, it's been everything. It's been labs at a time. It's been anything.
No. Not anymore.
Inpatient, outpatient, so it changes every day. I think, you can say that the days of the destination, cliffside, beautiful home to recover in are probably not as popular as they were, right? Like all these things continue to change.
His company owns Cliffside. Cliffside's a fabulous place. Everyone should go.
It is. All I mean is...
I take no offense to that. Cliffside is a very unique property for a unique clientele, but
Exactly.
Discovery is 95% in network, where you take the learnings of an organization that's very high end, but you bring it out, and I couldn't agree more with what Tim said. You want to be in an individual's own backyard when you're providing services, so I think that there will always be a high-end treatment program where you're doing the testing on what works, and then how do you roll that out into a broader community.
Yeah, so all I mean is that the model continually changes. It's not staying in one place. So for me to tell you, hey, this is the hot sector right now, it'll be different tomorrow.
Noted. Well, let's actually revisit, Tim, you touched on this, and Tani, you did a bit, on value-based care and outcomes. It's, Tani, this is a term that gets thrown around a lot, right? A lot of the folks in the audience here are providers or investors in post-acute healthcare. We have a lot of skilled nursing investors, providers in the audience here who've seen value-based care throughout their businesses. In your experience, do you think there's a world where there's a scorecard that evolves here in the foreseeable future, that insurance companies and managed care organizations are really basing their reimbursement off of?
There definitely should be. It makes perfect sense, and the templates are there. They have not, in my experience, yet really penetrated into the behavioral health space, because behavioral has, as illustrated by what Todd was describing, and there's more, but there's different markets within, and the markets within behavioral have different measures of clinical quality and cost. You also have a fairly fragmented, and more fragmented than a lot of other parts of healthcare, payer matrix, depending on which type of service you're providing, in what geography even. You're either in-network, out-of-network, government pay, maybe all of the above, and getting a uniform level of standards that everybody will adhere to has been extremely challenging. And before you can make the scorecard, you have to know what you're measuring. There's the new ASAM criteria. The new ASAM criteria should help clear at least some of the underbrush from most of the mental health and substance use parts, at least, of behavioral. Doesn't address ABA, and there's other ones it probably is missing as well. But I think you have to get a common language. Once you have a common language, then you can collect the data and you can present it. But right now, to Jacob's point, things change so much, and what one commercial payer likes may be different from what another commercial payer likes. I mean, Optum is in the business now. It owns companies. It's a provider and a payer, and so they have their own system. Anthem, and you just go down the line. I'd say until that bright, shining future arrives, in which it's a lot more simple and uniform, folks are best advised to try and align best to what their particular payers are. Who are the biggest payers that are going to move the needle in your business? What do they want? How can you give them more of what they want for less cost? If you think about this in their terms, you're more likely to become a better business partner to them. And I think Tim touched on this earlier, and I think it's a point that can't be reiterated enough. It acts like a faceless bureaucracy that can drive you crazy and do a lot of unjust, stupid things sometimes that need to be pushed back on legally. But in the end, I mean, they're your customer, and finding ways to give them what they need, which is more care for less money, and whatever lane you are will, I think, differentiate you from your competitors and pave the way for you to have the most of it. And one of the points you mentioned, Andrew, is kind of like integrated care. So value is how much behavioral can you deliver for a lower cost, but integrating this to the physical health sector is another thing that payers are interested in, and the data is there to show that if you can cover both and connect the care instead of treating them as two different silos of a patient experience, will give you a better health outcome. There's a lot of work to be done to realign behavioral and physical health care, but finding ways to do that is a measure of how do you, with the care that you provide, generate value. By the way, the payers, they may not really recognize it. You can have a great mental and physical health thing, and you can go and tell the payer, well, we're saving you all of this money in your physical health side, and I've heard from providers that the payers will tell you, well, that's really nice that you saved my colleagues in the physical health division a lot of money from their P&L, but we have a different P&L, and that's really nice. But there's a lot of sort of nuance that is happening right now, which hopefully will clarify, because I think it is going to give us a better system and better outcome and more care for less money. But until then, we have this kind of whack-a-mole environment slightly.
Yeah. Tim, I know you have a few thoughts on this. Anything else to add to what Tani said?
Well, thank God we're not the only ones that the insurance company talks to like that. Value-based care isn't here yet. Everyone's going to have different benchmarks, but I like to look at what else has happened in other areas of healthcare. Primary care roll-ups, the MRA scores drive what you're going to get reimbursed. There's no doubt that there are lines in there for behavioral and mental and substance abuse, and SNFs are now part of value-based care in a very small way right now. I believe a lot of the spend that's occurring on the mental and behavioral health side and substance is probably being driven through the ED admissions and the reoccurring admissions inside SNF and SNFs and ALFs. So to address that, you need behavioral health experts. I'm sure some people are going to try to go the route with doing it people that aren't in this space. The great thing about this space, this SUD, behavioral and mental, is very specialized on the labor side. The people are extremely committed to really great outcomes. It doesn't matter where I've gone in this country, that's a very, very common trait of the people that work in this space. So when value-based care does finally come and data is shared, they're going to be great at it. They're going to be really good at it.
Yeah, that's a good thought. I want to segue for a second into real estate for higher acuity behavioral health care centers. There's a lot of folks in our audience here that have ops and real estate experience. Some real estate investors specifically. And so, Todd, I want to ask you, as you're looking at a behavioral health care company, and let's just say that they own their own real estate, how are you thinking about valuation on the way in to that actual real estate?
I'll start from the vantage point that Webster prefers to not be the real estate owner. We tend to invest in the less capital-intensive side of the business. That said, we have businesses that have real estate. We have an IDD business that has group homes I think Matt Patinelli is around here someplace, and Capgrow is someone that we've spent time with. Others here we've had the opportunity to meet that might be a REIT for psychiatric hospitals. And so with Oceans, we don't own our real estate, but we do look at businesses where they do own the real estate. And so finding that REIT partner, that capital partner that understands how to do the diligence on the property. The things that become important to us, not somewhat stating the obvious, things like the cap rate. Very importantly, having a long-term lease as a private equity owner. Someday we will sell the business, and if the next owner doesn't have a long-term right to the building where a lot of our earnings are generated from the OpCo, that might make it harder to transact. Not always easy to get, but in certain areas we would prefer some type of purchase option at some point in the life of that asset. There are some owners that we might sell a business to that would prefer to own the real estate. So oftentimes it's those types of things more than just the value of the property. But ultimately, it comes back to what is our lease payment, how does that impact the cash flows of the business, and we have to get that right-sized, no different than we have to do with the debt that we might put on a business, that the company generates the appropriate level of free cash flows to service its lease payments that allow the company to grow. Final point I would say, having some flexibility as our businesses grow, we'd like to be able to add on to those facilities, and so having a partner that understands that component and can be a good capital partner to help those facilities grow would be important too. So that's some tangible, the tangible types of things we look at when we think about real estate, being involved in companies that we might be in partnership with.
Yeah. Thanks, Todd. All right, I'm going to ask my next question to you, Tani. It's a conversation we've had more than once, a few times, and I'm always curious, and hopefully, I think the audience may be interested in kind of getting your opinion of, individual kind of OpCo sales versus portfolio exits. The space has always been, a portfolio exit of an entire company. So you historically have grown, scaled, consolidated, and then exit to a strategic. Do you think there's a world in the foreseeable future, as more professional capital comes into the space, that you start to see individual OpCo, PropCo transactions, or regions of portfolios that are kind of being clipped off to then redeploy those proceeds into other states or sectors, right? That maybe that provider can manage better or just have better outcomes with. Do you think that world exists or no?
Candidly, it's far from where we are now. There are some things in behavioral that make it unique and much harder to treat regions or facilities as fungible or tradable separate from the whole. For one thing, from the top, when we were talking about valuations earlier, the way the market is now, if you have a platform and you have a successful platform, you're going to draw a much higher valuation than you will from a couple of facilities or add-on acquisitions. They're just different strata. And so breaking out some parts of a business, unless there's the parts that aren't as successful as the rest of the business and you're looking to divest and get out of something, right, that's certainly a reason why somebody might want to break something off. But generally speaking, you're going to get a better value with the whole company that's healthy, that's got a continuum of care. As Todd mentioned, you've got Cliffside Malibu and a whole bunch of other things, and you can share and synergize across the system. So I think it's far from where we are now. When we do deals, I'd say what is different in behavioral than you might see in PropCo, OpCo deals is there's a lot more variation for all the reasons that we're talking about now. A lot of corners to look around in due diligence, business and legal. And on top of all of those things, once something is plugged into a network and it's building value from patient acquisition to reimbursement strategy to managerial talent all down the line, sort of rewiring it into some other system is, the new buyer may have a totally different setup from EHR systems or no EHR systems, which is too common right now. So I think you've got a lot more mix and match, and unless it was a special situation that some larger market force was driving, and I've unfortunately been in charge of divesting a bunch of businesses that were being sold, but not for good reason. So there is some experience with that, but I don't see it as what's happening now. I think you have savvy investors who figure out which corners to look around or hire counsel and other advisors to help them do that. One of the groups that's here, we had just a completely wild deal with really every mix of weird legal issue things, on top of which you're in the behavioral health space, which meant that the owner-operator was completely bonkers. At one point, he was probably sort of sane, but it wasn't. And I think you shouldn't underestimate that. As Tim said, you have a lot of mission-driven people in the space, which is what makes it wonderful. But on the other hand, you can have people who may be a little too close to it or may not be in fully control of all their faculties, and it just adds this like X factor of weirdness and drama. And we got the deal done, and these guys did really a phenomenal job of getting through a lot of BS. But I think you've just got a more colorful level of mixed things that you're working with in behavioral. I think it's great. It's always interesting, and if you know what corners to look around, it becomes, at least on some level, it can be a little bit entertaining. So unfortunately, not yet, but that's not necessarily bad for what I do.
Yeah, no, understood. Any other thoughts? Like, how does the, Jacob, Todd, or Tim, how does the space see more transaction volume? Any other high-level thoughts on that?
I love the idea. To me, it seems like it's more active in the REIT world. We do get approached about repurposing assets, so maybe that's the starting point. I think we as investors could do well maybe to reach out to another investor and say, you have one facility in this market where we have 6, and we have one facility where you have 6. Is there a way to trade and be better equipped in a particular market? So, but I think this exchange idea that Jacob was speaking about, where they're trying to give more transparency, maybe that would be the door that would open the opportunity to move assets around as pieces as opposed to whole companies. You see doctors move around, so maybe why not facilities move around? I think it's a good idea. Transparency is probably the easiest way for that to happen.
So. Thank you. You mentioned destigmatization earlier. Obviously, the more the space becomes accepted, it's integrated with your physical health and primary health and so forth, more money that flows into it from the government, et cetera, the more it's going to be consolidated, the more deal flow there will be. Everybody will be much more comfortable with deploying those dollars. And I think the more we do these sort of events and educate people, the more it's not going to be, I'm afraid of private equity or the banker or the attorneys or all that stuff. I just want to take care of my patient. Well, you're going to understand that consolidation is inevitable. And eventually you're going to be able to help more patients in a better way with greater access and greater quality in wherever they are, et cetera, if you accept the whole consolidation process. So I think more deals will happen with more money and more care and more acceptance of what's going to happen.
Yeah,
regardless of whether or not they participate.
Yeah, I totally agree with that. And obviously, you and I need to see more transactions, right? But at the end of the day, this industry, I was just having a conversation a little bit earlier. I mean, this industry, to me, and I have some background in post-acute healthcare and skilled nursing, and it's skilled nursing, from a certain aspect and lens, 30, 40 years ago. And as professional capital comes into the space, I mean, there's providers that, everything is consolidated up, right? And it's difficult to see unit economics of individual facilities. And I think, as certain aspects, and, there's a lot of not-for-profits in the space, I think there's just see more transactions as more for-profit, more professional investors come into the space, and more groups start looking at unit-level economics and building scale, in and around certain geographic regions, I think there is an opportunity to see more transactions, but also agree with what you're saying. It's difficult, and it's not there yet.
One thing that could help it that doesn't yet exist right now is have separate managerial services in behavioral. You have a lot more of that in senior living, and we've had senior living clients come to us and say, hey, a good manager for a behavioral facility, and it's not a separate service provider. The management is integrated in largely through behavioral. And so that's one of the things that you'd need that piece to better be able to focus on the unit economics and not have to worry about the complexity of management and make management more fungible.
Yep, that makes sense.
Just make a quick add on to that comment, and it goes back to some of the value-based care comments. Scale will matter if you want to develop a value-based contract to understand all of the data that you need to make a good deal with a payer. And so it does lend itself to a reason for further consolidation in the sector to be able to make the investment in the data and analytics and tools that you would need to measure that. Rolling out EMRs inside of these facilities, all of those types of things that you're going to need. And the last comment I'd add for emphasis, as capital investors, we're seeking places where there is not enough care and places where our capital can be used to provide more access points. So I've not found very often that there's economies of scales of putting a bunch of businesses together and expecting that you can find some synergies in the middle, particularly in behavioral. The revenue cycle piece, again, until something changes, you need about as many people for one facility, for each of those facilities. Once you put them together, you can't get rid of 10 people if you put several places together. So our goal is to find those places where there's not enough services and where can we make investments to get those access points out into the communities. And final point, that may be partnering with a health system. You look at Oceans, a lot of health systems, their capital has really been a challenge the past many years coming out of COVID. They need more psychiatric care and mental health services in their community. Can we bring capital to help one of our companies partner with a health system to get more access in the community? So those are some of the things that go through our head as we invest here.
Got it. Well, I do want to leave some time just for some Q&A here for a few minutes, if we can. So I don't know if there's a microphone out there. Or anybody has any questions? If not, we can keep going up here with a couple more. But anybody have any questions for our panelists here? Wow, we really knocked it out of the park, huh?
You asked a lot of questions.
All right, I got one more. Yeah, go ahead. Yeah, Drew.
What's next? I mean, a eulogy should be provided for telemedicine because, billions of dollars have been spray painted across HCIT and telemedicine companies, and I don't think there's a unicorn left. I'm not even sure there's a gopher left. So what happens next?
I get a very quick answer that you guys can answer correctly, but the next session is on telehealth. I think those guys will probably have the answers.
It seems like people being able to, a virtual reality goggle where your avatar is in session talking to people, and so they're more comfortable. Again, I don't know that that's going to be mainstream, but it does seem that when people have an alternate ID or reality, that they're able to open up more about traumas they've had. So, I worry about things like virtual reality, but I do think there may be some applications for that. It's certainly proven itself in autism as being able to have some ways to help individuals change how they interact with the world. So again, I don't think it's going to be big and mainstream and totally change the industry, but I think there'll be areas where if you think about what else could happen in virtual, that's something that might happen in the next 5 years. It's interesting.
I would say as part of a care continuum, telehealth is alive and well. I'm sure your portcos are using it, and My question for you, Todd, would be, do you see a world where one of your bricks and mortar portcos might want to buy one of those previously high-flying and tech-enabled places and have kind of bricks and clicks together to expand the continuum?
In many of our companies, we've been building that without, so many of those businesses are more about the marketing side, and you see Talkspace spending, $100 million a year to get their name out. We're doing it more exactly as you say, your care continuum. Everything that you described, if we can step a individual down and have that community-based service for them, or somebody can notice something maybe isn't going right for that individual and help be there faster, I think that's probably the pathway closer for what we'll be doing.
Perfect. I think we're almost on cue. I don't know if we have one more question available or not. And we'll take one more. All right.
I'm just curious what you're most focused on related to redeterminations in terms of platform investments, in terms of wait-and-see approach versus, kind of to get comfortable with the new platform.
Yeah, as you've seen, you don't want me to be the last one to answer a question, or you'll be well into the next session. Look, it's complicated right now. Certain states, my quick observation is states that have not gone through Medicaid expansion probably have less of that issue than states that did. And a lot of those individuals, mothers and children, I think they're finding new pathways to keep more of them on that may have found their way through the window. But it definitely, the next 18 months, it's going to be a big focus area as we look at companies, particularly that are Medicaid driven from a reimbursement standpoint.
Very good. Well, round of applause for our panelists. Thanks everybody so much for coming. All right.